I bring to you greetings from the Ganga Institute of Medical Science, and I'm extremely happy and delighted for giving me an opportunity to speak in the first webinar organized by the Regional Anesthesia Forum, Jaipur. And I sincerely thank Professor Dr. Vandana Mangal, who has taken enormous strains and efforts to make this a possibility. Regional anesthesia has made tremendous inroads in the past 3 decades. Initially, way back in 1920s and 30s, there was a surge of use of regional anesthetic technique, and after which it all belonged to general anesthesia. Nearly 60 years, like 6 decades after 1930, we saw a rapid stride in the way general anesthesia became popular. But again, it is the last 20 years that there has been a resurgence in regional anesthesia for the good to the patient who comes for perioperative care and surgery. I bring to greetings from this institute where I work, and by virtue of being a tertiary care referral center for orthopedic surgery, plastic surgery, trauma, and major reconstructive surgery, most of the procedures in our hospital is done under regional anesthesia. Probably to the tune of 80% is under regional anesthetic procedure. This is the team that works in our institution. Anesthesiologists are real special children of God, because all the critically ill patients in an institution, if they need to survive, they need the help of an anesthesiologist to become better. And if you see, an anesthesiologist goes through all the known medical subjects, right from physiology to anatomy to pharmacology to medicine to OG to psychology, psychiatry. So they need to know about every aspect of medicine to be a good perioperative physician. So it is indeed a mother of modern medicine. But most importantly, the role of anesthesiologist seems to be in alleviating pain, and hence regional anesthesia is a huge weapon in his hand, and when appropriately used, it becomes so comfortable to the patient in the perioperative period. So it becomes extremely crucial and important that every anesthesiologist who is practicing anesthesia in the globe today have to move over from the imprisoned zone of being a bonsai plant to grow like a big banyan tree by encompassing the various facets of regional anesthesia. Now, first question I would like to ask each one of you, please tell yourself an answer. Which is the most important equipment according to you in regional anesthesia? I wanted each one of you to choose an answer for yourself. I'm going to give you 10 seconds. Which is the most important equipment according to you in regional anesthesia? I'm sure that each one of you have now thought of something, and please keep that in your mind and see if it correlates with the answer which I'm going to give you now. According to me, the most important equipment in regional anesthesia is the anesthesiologist himself. I'm not too sure how many of you had this answer when the question was asked. The reason is, whether you give a neuraxial block like a spinal or a epidural or a combined spinal epidural, if you actually analyze, the skill of the anesthesiologist developed over years is of great significance, which is equal to possibly any equipment that is produced in this world to aid him to successfully perform a regional block or a neuraxial block. Now, in a difficult spinal, in a difficult epidural, we always see some anesthesiologists are so skillful that they do it with tremendous amount of expertise. But why is it so? Why is that some of them have the virtues of being an excellent and skillful regional anesthetist, while some are not? And I have some answers for this. I've been introspecting on this for several years, and I find it very nice to note that there are certain aspects of a regional anesthetist. Now, when you are performing, for example, a combined spinal epidural, if you use the combined spinal epidural needle in a very specific way, all along the ears, the way you hold it, the way you're putting pressure on the tip of your fingers and you're controlling and guiding the needle inside, if you keep on doing it the same way, so one aspect of your thumb, one aspect of the tip of your index finger, and one aspect of the tip of your middle finger will be constantly perceiving the impedance that is offered by the tissues, the resistance offered by the tissues as you go from the skin to the epidural space. Over a period of time, what happens is your eye comes to your fingertips. Your eye is in your fingertips. So as you move inside, you start feeling every structure that you are passing through. And this amounts to the success of some over the other in regional anesthesia, especially in neuraxial blocks, and also sometimes the peripheral nerve blocks, which are done with landmark technique. Is it substantiated by scientific evidence? So this is very interesting to note. The sensory neuroscience, there is an article from skin to object in the somatosensory cortex. The tip of the finger that you use the most is highly represented in the somatosensory cortex. So what happens is your ability to perceive things becomes better. This is something extremely interesting and very important, which I would wanted to convey to you. So for all the youngsters who are listening to this webinar, I request you to perfect the art of using a spinal or an epidural needle. Every time you do the same way, every time you do in such a way, the way you hold the needle, which part of your thumb or which part of your index finger is applying pressure as you go inside. If try to make it the same, the block after the block, and that part of your thumb or that part of your finger gets highly represented in the somatosensory cortex, and your spinals and epidurals will become easier and easier, and your ability to perceive the tissues becomes easier and easier. So the neural mechanism of tactile motion integration in somatosensory cortex is a brilliant article which actually summarizes the truth that I'm speaking. And segregation of tactile input features in neurons of the cuneate nucleus. Cuneate nucleus in the brain seems to form an important component of transmitting this perception to the sensory cortex. So there are some studies which have been shown by recordings that happens when you're performing a particular procedure, the way the tips of the finger are highly represented. So I would want it, the take-home message is, if you want to perfect your neuraxial blocks without the aid of an equipment or an instrument, I would suggest that you follow certain strict protocols of holding the needle, and you will be going to be highly successful. Before I embark into the journey of talking about the several equipments, the most important thing that I would wanted to let all of the youngsters to know is the hand hygiene. Before you perform anything, whether it's a peripheral block or whether it's a neuraxial block, you should not be a component of producing a hospital-acquired infection to your patient. And hence, I consider it is very, very important for a good hand hygiene before you do any procedure. And this is the most important second equipment that I would wanted to let everyone know, because hand carries a huge amount of colonies, and the subungual areas have the highest bacterial concentration, and it is crucial and vital that you give it a lot of importance. And it's also important that we do the steps of hand washing in the prescribed and the described format, so that we don't transmit an infection when we offer our services to the patient. And also, next important thing that I would wanted to let you know is safe practices. The syringes that you use should not be shared, and the same syringe should not be used for taking different or loading different drugs in regional anesthesia. No contamination should happen, and this is the important message which I would wanted to convey to you. When you load the drugs, for example, when you want to infiltrate locally, when you give spinal anesthesia, first you load lignocaine, the plain lignocaine that you load, and you load it from a vial. So whenever you use a multi-dose vial, it is a great practice to sterilize the diaphragm of the vial with 70% alcohol. So this is the best way to make it aseptic, and then you draw the local anesthetic solution which you wanted to use. These are small things, but I think very, very important things, especially when you do a neuraxial block, to make sure that you don't produce any meningitis or meningoencephalitis. And this is a good practice which I would wanted to convey to you, which we do religiously to all the patients. Elective admissions which undergo procedures here to enhance the antisepsis, we give them an antibiotic shower the day prior to the surgery and on the day of the surgery, so that your regional blocks, especially when you use, for example, an axillary block, or when you wanted to do a groin level, you want to do a femoral block, the bioburden is decreased. So we use an antibiotic shower. Usually, this is a chlorhexidine bath, which is given the day prior to the surgery and on the day of the surgery. Instead of the usual, the detergent soap they use, they go in for a chlorhexidine shower. This has seemed to be a help decreased the hospital acquired surgical site infections in our patient. And the other equipments to make sure that you are working in a very comfortable atmosphere and your patient is very comfortable is to make sure that especially in the COVID times, that your air exchange in the operating theater should be minimal 20 cycles per hour. Please ensure that you have 20 air exchanges per hour when you're using a positive pressure ventilation theaters, and you need to keep the temperature at around 18 degrees and the humidity between 50 to 55 degrees, something which is very vital for anesthesiologists to follow. Neuraxial procedures needed much more and very clear asepsis, and I would wanted every one of you who are doing a neuraxial procedure to do a hand wash minimum for 6 minutes on the first time that you enter the operating room, and subsequently the prescription is 3 minutes, whether you do it with chlorhexidine in alcohol or whether you will do it with betadine. And then clean the area with betadine, and a contact time of minimum 2 minutes is good. In the back of the patient, when you paint it, when you want to use a neuraxial block, I would recommend that you give a contact time of minimum 2 minutes. This is something which is very important to be followed religiously by clock. And after the skin preparation is done, then you will, if you place a catheter inside, you make sure the entire epidural catheter is completely kept as a closed system. Frequent disconnection should not be done, and frequent injection should, if at all you decide to give an epidural top-up, it has to be done under sterile aseptic maneuver that you would use. So, and also I would request all of you to completely use a surgical glove and the surgical apron and the glove that you use. The CDC has recommended when you do a neuraxial block, they have requested to all of us to use a glove which does not have a powder, because this powder can produce chemical meningitis. This is another important take-home message that I want to give. So when you do embark on the journey of a neuraxial block, the equipment that you use to keep yourself sterile is a glove, and the glove should be a glove which does not have a powder. Non-powdered gloves are available. So I wanted to drive home this message to prevent a chemical meningitis. So this is how a central neuraxial block should be done. And henceforth, nobody should just wear a glove and go and give a neuraxial block. It has to be done with strict asepsis. And I have some interesting factor. When you paint and drape a patient for a neuraxial block, I use another small equipment, especially in obese patients, that the sheath that covers the combined spinal epidural needle, the spinal needle in a combined epidural set, is this sheath, which I've on the right side of the picture, you see it's about 13.5 centimeters. So when I have a difficult back, like for example, the patient is extremely obese, and in the pre-anesthetic evaluation, I find that it's difficult to palpate the interspinous space. So what I do is, the reason I'm mentioning here is, when you paint the patient for a neuraxial block, you paint it up to the intergluteal cleft. Okay, especially when it is a difficult spinal. Please paint it under the intergluteal cleft. On the left side of the picture, you will see the intergluteal cleft. On the right side, you see that I'm using the sterile sheath which covers the spinal needle of a combined spinal epidural, which is got a length of 13.5 centimeter. So you put one tip at the intergluteal cleft, and the other tip will, you see on the cephalad portion, you make a mark there, and that is the point of entry of your needle. Believe me, you will succeed all the time you do this in obese individuals. Please try this in the next neuraxial block that you're giving. Later, we wanted to see the scientific basis of this, and we used ultrasound to see which part of the spine this belonged to. Majority of the time, about 64% of the time, it was between L3 and L4, and the rest of the time it was between L2 and L3. But this is a clear way to be in the midline to make sure that you get a successful neuraxial block. So it's a small piece of equipment which I would just wanted to convey to you, which would be of great help to you when you deal with a patient whom you cannot feel the interspinous space. And this is something, this equipment, the glove, every postgraduate entering the department should know exactly the way to wear a glove, and it's too important for the seniors to educate them. This equipment is so important to make sure the asepsis is maintained throughout. Now, with this pandemic on, one of the most important word that comes across to us is personal protective equipment. I think this has become an inherent component of any form of anesthesia, be it regional or be it general anesthesia. And I don't want to speak more on it, but I just wanted to emphasize that when you embark on the journey of giving a regional anesthetic procedure in this pandemic, I think it's a great idea, especially if you are in hotspots. It's best to go with a complete PPE before you do a block. And another equipment which is of very crucial importance in this pandemic is to see the oxygen saturation, because this is the era of happy hypoxia, and this is a small piece of equipment during your perioperative period which will help us. One of the commonest procedures that we do is the spinal anesthesia, and the needles that are used are called spinal needles or the intrathecal needles. I only wish that this spinal needle was available for people in the 16th and 17th century. Suppose if you and I were born in the 16th century, there was no spinal anesthesia. None of them knew about spinal anesthesia. So it was just the brilliance of a person called Kotungu, who described the presence of water around the brain and inside the spinal column. And it was Magendie who described that this fluid circulated around the brain and the spinal cord. See, imagine what a big idea that has come to them, because otherwise there could have been no spinal anesthesia even today. So this was the brilliance of these two men who showed that there is a fluid that is circulating. And it was the brilliance of Leonard Conning who first administered the spinal accidentally, but later it became a part of the process. So a lot of credits goes to Quincke, who described the first cutting spinal needle, and the August Beer, who was the one who provided analgesia along with him, and for his assistant performed this block very scientifically. But the standard spinal needle which are present today is the great work of a combination of Quincke with Babcock. So they kind of made the needle much more standardized for a good use. And later, we went for atraumatic needle tips. The Quincke-Babcock needles produced PDPH, and then came in this atraumatic needle tips, which came in 1920s. And it was a realization that the cutting needles produce a bigger leakage of CSF and a postdural puncture headache. It is to the brilliance of Green, who presented his needle, which produced a very, very, very small hole in the dura, and it resulted in a PDPH of less than 4%. So when you started using smaller needles, then it became important that you have a stillet within the needle, and the stillet also prevents taking the skin core tissue from the skin into the CSF. So sometimes when you do a pediatric spinal, I have seen people using a hypodermic needle to give a caudal or a spinal. This needs to be not encouraged, because when you do a spinal with a needle which does not have a stillet, it carries the tissue from the exterior to the interior, which could produce significant infection. So this needs to be avoided. And if you see, a spinal needle has got several components. So the needle shaft with the, here is a picture which I've shown. You see the bevel, the needle hub, the stillet. The stillet, it's very, very important that the stillet comes until the tip and it occludes the distal lumen, and we have a color-coded stillet hub. The color-coded stillet hub will tell which size of spinal needle that you're using. Most of the spinal needle are 10 centimeters, but special needles are available for obese individual. So 15 centimeter spinal needles are available. And as much as I know that India, it's marketed by Becton and Dickinson. So it is good that every department possesses a needle which has got a length of 15 centimeters. The size of the spinal needles that are produced range from 16 gauge to 30 gauge, but the commonest used is 23, 25, 27. And what is the difference between the two in relation to PDPH when you use a Quincke needle? When you use a Quincke needle, 23 gauge needle, it is sure 1 in 3 patients will get a postdural puncture headache to the tune of 30%. When you use a 25 gauge needle, the incidence is decreased. It is close to 1 in 4% that will get. And when you go to 27 gauge, it is just 2%. So only when you give 100 spinals with the 27 gauge will 2 people develop a postdural puncture headache. So this is something which all of us have to know. So if you want to avoid a PDPH, it's better to go for a 27 gauge needle rather than to go for 25. And if you want to use a 27 gauge needle, because it is very thin, and if you need to perform it, the skin and the subcutaneous tissue offers severe resistance to pass this small 27 gauge needle, and it will start bending. To make it easier, then Sissy, Lincoln F. Sissy introduced a concept called Sissy Introducer, which is a 2-inch length. And there are different types of introducers which are available, named after Corning and Lundy. So the toughest part of the journey of the spinal needle, the skin and the subcutaneous tissue, you put the introducer, and through that you pass the 27 gauge needle. So these are the several specifications of colors for different kinds of spinal needles that are available, which I think most of you know. And the most important thing is the Quincke, as you see, I just want all of you to appreciate the cutting part. It's very nice to give with this because it pierces the tissue very well. There are a few other needles which are available, like a Quincke needle. It is also called as Yale needle or Pitkin needle. But then we understood that this can produce postdural puncture headache, and we started going in for non-cutting atraumatic pencil point needles. And the the winners of this is Whittaker needle and Sproats needle. So these are the bevels which you see, the differences between Twinkie, Whittaker, and Sproat needle. And these are some of the other needles that you see which are commercially available. And you see the difference is only in the bevel. And there are any number of them. You see 6 different kinds of needles, spinal needles, which are available, which are commercially available as well. And these are also needles which you may not have seen, but again, commercially available with different logistics and Levy and Atracan, etc. So this is just to give you an idea that with the pencil point needle, apart from the Whittaker needle, you also have several other needles like Eldor and ball pen, which are commercially available, which probably we may not have seen. And this is the spinal kit, which is available in the market. And it is a complete kit, which is along with the antiseptic up to the needle with the local anesthetic solutions, everything. So this kit is available in several places. Next important thing, which I would wanted to emphasize, is the Luer slip and Luer lock syringes. By accident, if you inject something which should not have gone into the intrathecal space or an epidural space, which can produce severe infection in this region, it is important that you have to have a mechanism which will prevent this accidental slip from happening. So as an institutional protocol, if you say you will use only Luer lock syringes for your neuraxial catheters, and you will use probably a Luer slip for all the other things, we can prevent errors which are happening, which could sometimes be catastrophic. Now we move on to a continuous spinal anesthesia, something which has caught the imagination of several physicians and several anesthesiologists. And slowly, with the advent of microcatheters with the filter, continuous spinal anesthesia is gaining momentum. There are few centers in India which do continuous spinal anesthesia with a lot of proficiency. And if you see what are the indications of using a continuous spinal anesthesia, maternal cardiac disease, where when you use a CSCA, very slow titration, very small incremental bolus that you give, you produce a profound surgical anesthesia with least hemodynamic disturbances. This is akin to what we call it as a segmental epidural anesthesia. But the difference is this is much more profound anesthesia and analgesia that you offer the patient. In patients with morbid obesity, where you're very concerned about a high spinal, it is very nice to use a continuous spinal with very, very decreased dose that you place into the intrathecal space. Patients who are having prior spinal surgery, where there are a lot of adhesions that are present in the epidural space, you can go for a continuous spinal anesthesia. So there seems to be a definitive advantage of using a continuous spinal anesthesia in few of the patients who will richly benefit from this. The equipment of combined spinal anesthesia ranges from the normal standard epidural set, but which has got a macro catheter, to specially designed spinal microcatheters. So equipments of continuous spinal anesthesia are divided into 3 forms. One is catheter over needle set, second, catheter through needle set, and third, epidural catheter inside needle technique. And the catheter over needle set, there are 2 widely used sets. One is Spinocat, other is Wiley Spinal. These are beautiful sets of instruments. So this is the Spinocat. I just wanted to concentrate on this picture. Then you will see, can you see the catheter, which is earmarked, the 22 gauge catheter. So that is the catheter. And you will see there is a small string that is attached to the needle. So there is a catheter. The outermost covering is the Tuhi needle. Inside that you have the catheter. Inside the catheter you have the needle. So the needle is pushed inside, and once it reaches the intrathecal space, then using the string that is behind that you see in the back, slowly the needle is pulled out and the catheter is pushed in. This is how a spinocath actually works. So can you just see, this is the place where the CSF emanates, and this is the needle, and this is the catheter. So the needle is within the catheter, and above that is the Tuohy needle. So now once this needle reaches the cerebrospinal fluid, starts emanating intrathecal space, you pull this string and slowly remove this needle, and the catheter, this is the catheter that is placed inside. How much to keep inside? 3 centimeters. So the advocacy is to keep 3 centimeters of the spinal catheter inside. So it's really a great advantage. And also I would wanted to tell you the difference between, a lot of people ask, if you use a continuous spinal, will there be more PDPH? Will there be a persistent leak? Spinocath is an answer for this. If you see this picture, there is no CSF leak because this is the needle and this is the catheter. So, and this is the tissue, the dura. So now what happens is when you remove the needle, there is no space between the tissue and the catheter. So there is no CSF leak. So spinocath has been found to be a very good model to use a continuous spinal anesthesia. So this is just to give you another variety, the Wiley spinal catheter. It's again a very, very nice form. And the next one we go for is catheter through the needle set. And the best one which we know is manufactured by Payang. It's called the intra-long set. And I just wanted to mention this because these are all commercially available and it could be used. This is what you see in the intra-long kit. The difference is, if you see the tip of the needle through which the catheter comes out. So you see the catheter is coming out through this. So this is the intra-long kit. So as I discussed with you, the catheter should not be kept more than 3 centimeters, because if you do so, the catheter can curl up in the intrathecal space, and sometimes it may snare the nerve roots, especially when you're trying to remove it. Then from the continuous spinal anesthesia, we move on to the next important one which we do, uses the epidural needles. Full credit goes to Tuohy, Edward Boyce Tuohy, who designed this curved needle tip, and it's called Huber point. If you see the epidural, the needle that devised by Tuohy has got a Huber point, which is a curved one, which prevents when you want to put the catheter inside, the catheter enters the space smoothly without getting injured or sheared. So this epidural needle made waves where it was possible to prolong the duration of neuraxial block, and the full credit goes to some of the excellent people who did this. Corbello, Philip Bromage, who established the continuous catheter with perfection. And the commonly used needle is Tuohy's needle. You have the other needle called as modified Tuohy's needle, which is also called as Tuohy-Hustad needle. We have the Sprout special needle, which has got a conical tip. We have got a Weiss epidural needle. We have a Portex needle. We have blunt tip epidural needles. So there are several epidural needles that are manufactured apart from the commonly known Tuohy's needle. This is the clear depiction of how an epidural needle looks like, with a marking of every centimeter. This is very important. This graduated marking is very important for you to know at what depth that you reach the epidural space and how much epidural catheter that you need to push inside. So it's a good practice for all the postgraduates to keep a clear note when they push the epidural needle inside, how much has gone inside. So if you see the last the last 1, 2, and 3, see, these are not marked. From here, these are next 5 centimeter is marked. So of the 8 centimeters, the first 3 centimeters, because usually epidural space is at the depth of 3 to 6 centimeters. So the first 3 centimeters is not marked, followed by which every centimeter that is marked in different colors, the graded colors, brown and silver, every 1 centimeter is marked like this. So the pediatric epidural needles, it is available. Is it available commercially? Answer is yes. And the pediatric epidural needle, the size is 5 centimeter long, and it is usually available in 19 gauge. And it allows a 21G catheter to be placed inside. And I would wanted all the anesthesiologists to know that those who deal with pediatric anesthesia, it's a great idea to use this rather than an adult needle. So this is the other needle which just I wanted to show you that there were some questions about, is there an epidural needle available other than that? So this is how a Protease epidural needle looks like. See the tip, which is completely different from the Huber point needle. Now this is very interesting. So you see different kind of epidural needle and the way it has been designed. So there is the Huber point epidural needle, and then the Toohey flower needle, then Husted epidural needle, Weiss epidural needle, and the special Sprott epidural needle, and the Crawford epidural needle. So there are so many different forms of epidural needle that's available. And I'm a great proponent of combined spinal epidural anesthesia. I'm not too sure that how much is used in this country, but I am a very, very strong proponent of combined spinal epidural. And I also firmly believe that it's a great idea when you decide to go for a combined spinal epidural to use a needle through needle, because with a single puncture, you can enter into both the interthecal space and then give an epidural placement. Why is that I like this so much? I find it extremely useful because when you use a combined spinal epidural, you drastically decrease the intrathecal volume of local anesthetic solution that you place. And because of this, you produce least disturbance in the hemodynamics. And by the virtue of having an epidural catheter in situ, when the 2-segment regression happens after 45 to 60 minutes, you supplement local anesthesia, attain the same level of surgical anesthesia. This is extremely handy when you do this in orthopedic geriatric patient who come in. I think this is the single most important technique for all the youngsters to use when they deal with geriatrics. By virtue of being an orthopedic hospital, we get plenty of hip fractures in the age group of 90 years and sometimes 100 years. So when I use a combined spinal epidural for a patient who is 100 years old, the intrathecal volume that I place is 0.5 ml of the 5% bupivacaine heavy. Between 90 to 100 years, I give about 0.6 to 0.8 ml, and between 80 to 90, I give 1 ml. Between 70 to 80, I give 1.2 ml of 0.5% bupivacaine heavy. Believe me, it produces an excellent quality of surgical anesthesia until D10, which is what is required for a hip fracture without producing any hemodynamic disturbances. And the only thing that you need to keep in mind is the 2-segment regression happens within 45 minutes when you use such a low dose, and you need to be prepared to give an epidural top-up. A lumbar, like the lumbar region, for every level, they need 1.5 ml of local anesthetic solution. So if there is a 2-segment regression, you need to give 3 ml. So at the end of 45th minute, after giving spinal, you start giving epidural top-ups, 3 ml. For example, if you're using 0.5% bupivacaine, you give it for every 30 minutes, 3 ml. So there is a 2-segment regression. You give 3 ml. Again, the surgical, the anesthesia the level will go high. So this is the beauty of a combined spinal epidural needle. So several sets that are available for the giving combined spinal epidural. But what is interesting is the localization of the epidural space. This is far more interesting than spinal because of the pressure that is present, the negative pressure that is present in the epidural space. Methods that have been found to identify the epidural space are divided into 3 categories. guiding the needle to the epidural space, identifying entry into the epidural space, and confirming the catheter location in the epidural space. So with the advent of ultrasound, the best way to guide your needle to the epidural space seems to be the ultrasound. But it is also done in places where there is no ultrasound. It is done with fluoroscopy, and sometimes also they use this acoustic radiation force impulse imaging. So the ultrasound guided technique, as I said, it's a real time and it's extremely useful. In fact, you can actually use it preoperatively, and you can note down the space, the distance, and you see the posterior element. For example, if you see in this picture, so this is the posterior part. You see, you use a curvilinear probe, and you have kept it on the interspinous space. And you see this is the erector spinae muscle, and here you see this is the L4, and this is the L5, and here you see this area is the epidural space. And here you see the hyperechoic here is the posterior complex. And so, you know, the ultrasound has completely changed the way you locate the epidural space. And here I just wanted to show you. So here is the ligamentum flavum, and here is the epidural space. And here you see L4 and L5 spine. So a clear visualization can be done with the advent of ultrasound guided neuraxial block. So in places where it is not available, and in some chronic pain physicians, they are more used to fluoroscopy, and they use fluoroscopy to place the epidural injections. Then we have this acoustic radiation force impulse imaging. It's a technology which I just wanted to know, wanted all of you to know that there is something like that. This is existing. And to identify the entry into the epidural space, there are so many techniques. I'll just briefly mention to you to make and to show you. So many people have worked on this potential space. And many of this probably we don't read, but it's exciting to see that so many things has been done to a space which we normally encroach with our epidural injection or combined spinal epidural. So the first one is loss of resistant technique. For this, to identify this, you have membrane in syringe technique, an epidural balloon, an epidrum, an epi-Schuer auto-detect, and there are auditory and visual display of pressure waves, hanging drop technique. And there's another method which is used, which is called as bioimpedance, which uses optical reflectance spectroscopy and optical coherence tomography. It is too exciting, is it not? So we have not thought that people have worked on this space so much. So one is the loss of resistance technique. And this is the normal way that an LOR technique is being used. And membrane in syringe technique. Everything is based upon the negative pressure. So the minute you reach the epidural needle, reaches the epidural space, the saline which was present inside the syringe gets pushed inside, and we know that we have reached the epidural space. In the epidural balloon, you know, the balloon which is completely filled in, the minute the tip of the needle reaches the epidural space, it completely flattens because it empties whatever the content present inside the balloon. So that is the epidural balloon. The epidrum. So the penetration into the space results in sudden collapse of the diaphragm because of the negative pressure. So I will show in the next picture the epidrum. So this is the equipment which is used. It's a beautiful technology, the epidrum, and epi-Schuer auto-detect. So this is marked by the forward movement of the plunger of the emptying syringe. So this is the syringe which is used. It has got a syringe barrel and a compression spring and a gasket. So it moves forward the minute you reach the epidural space. So this is called epi-Schuer syringe. And more exciting is the auditory and visual display of pressure waves. This is again extremely interesting. And the epidural pressure detector. So this is another equipment which has been designed. And the drop-in pressure, if it's more than 20 millimeters of mercury, which is sustained for more than 5 seconds, then it is consistent that you have reached the epidural space. What a thought process that has been. So this is the pressure detector, and a drop-in pressure that you see in the pressure detector, which is sustained for more than 5 seconds, then it is consistent that you are in the epidural space. And this is something which all of you would have known, that is the hanging drop technique. Then we go into bioimpedance. So bioimpedance is a measure of what you see, the property that you see because of the differentiation in the tissues, the muscles and the fat. So based on this, we have what is called as optical reflectance spectroscopy and optical coherence tomography. I just wanted to mention these names to show that so much of work has been done in trying to identify the epidural space. Then to confirm the catheter location in the epidural space, there are another few methodologies like epidural stimulation test, electrocardiography guided system, epidurography, epidural pressure waveform analysis, near infrared tracking system, and ultrasound. So I'm not going to go into each one of them for the interest of time, but I just would wanted to tell you there are so many exciting things to make sure that your catheter is in place. So this is something very interesting, epidural pressure waveform analysis, and it seems to be extremely consistent. And this is a typical epidural waveform that you see. And it is possible to do this with the multi-parameter pressure monitoring devices. So here you see the ECG, here you see the saturation, and here you see the epidural waveform and the CVP. It is exciting, is it not? So epidural pressure waveform can also be continuously monitored intraoperatively. And then the other thing we have is the near infrared tracking system. It's a fiber optic wire-based tracking system to see the presence of epidural catheter inside. So the types of combined spinal epidural needle varies from 2-His needle. There is a single lumen and there is a double lumen 2-His needle. This is also interesting. There are two adjacent needles, and through one you pass the catheter and through the other one you pass the spinal needle. Then you also have got the Portex secure CSC needle. So these are the various different forms of the epidural needle. And the beauty of a combined spinal epidural lies in the way you lock the spinal needle over the epidural hub. So CSC is secure, and there are various technologies that has been propagated to make sure each company which markets it has got some beautiful system to make sure that it snugly fits in. So the spinal needle is turned clockwise in this particular CSC set to make sure that it firmly fixed to the epidural needle, and then you inject the drug. So this is another lock which is available. It's called EpiSpin lock. And epidural catheters, what are they made up of? The epidural catheters are primarily radio opaque. So if you want to see an image of where the catheter tip is, you can see. So they are radio opaque. Usually they are made up of a poly PVC material or a nylon material. And as you know, they are graduated. The tip is atraumatic, it is rounded, and it has lateral holes. And the catheter size in a 16 gauge, you have got a 21 gauge catheter. What is the diameter of the catheter? The diameter of the catheter is 0.9 millimeters when you use an 18 gauge epidural needle, and it's 1.1 millimeter diameter when you use a 16 gauge needle. So this is the diameter of the catheter. And as you know that the blue color is 18 gauge and light blue color is 16 gauge for the epidural needle. And that's the catheter which is graduated. So usually the catheter is placed 3 to 5 centimeters within the epidural space. The proximal end of the catheter has a Luer lock and filter. And this is very important for you to know. The epidural filter is a hydrophilic filter which has got the 0.22 micron mesh. This is important. So kindly use epidural infusions with the epidural filter in place, because it will filter all the virus, the bacteria, everything entering into the body. So this filter is very important. I wanted to emphasize this 0.22 micron mesh that is used in. And the second point that I would wanted to mention is whenever you deal with the epidural catheters or a continuous spinal catheters, the syringes that you use are all based on Luer lock, so that you don't put a Luer slip the syringe into this catheter. So these are the filters that you have. This is something which I really wanted to share with you. We use for fixing an epidural catheter, we used a specific material called as sterizone. What is the advantage of sterizone? This is a beautiful piece of equipment of your regional anesthesia, because in the center, if you can see this, in the center there is a small gauze piece, and this absorbs the small amount of serous fluid that is coming out from the epidural space, and outside you see a transparent sheath, which is the sticking material. And this is a great advantage, because if I don't use this, many times what happens, the serous discharge that is coming out of the peritubal space from the skin, which emanates out, produces a layer of fluid between the adhesive and the skin, and after some time the adhesive gives off, resulting in the epidural catheter coming out. And when you put on continuous infusions, you see it's a failure because the catheter has come out. So the sterizone is a nice piece of equipment which I would wanted to share with you, which I've been using for several years now. And this, to fix the catheter, we have got this beautiful plaster. If you see the plaster, can you see there are pores? So this breathes. So the sweat which emanates, especially in countries like India, where the temperature is very, very high. So what happens is profuse sweating takes place. And when profuse sweating takes place, if you want the sweat to come out, you can use this particular brand. It's Fixomal, it's called, to fix the epidural catheter. And the elastomeric infusion pump to give a continuous the epidural anesthesia. So we have univariate and multivariate pumps, where you can, in univariate, it is fixed. It's 5 ml per hour of infusion which is going. In a multivariate, it can vary from as low as 2 ml to as high as 12 ml, sometimes 14 ml. And the capacities of elastomeric infusion pumps that are available vary. 1-day pump, 2-day pump, and 3-day pump are available. Initially, it was used in cancer therapy, and now it is used in acute postoperative pain, both for continuous infusions of epidural and also in regional anesthesia. Next, we move on to one of the interesting factors is the nerve stimulators. Many of them are available. And why is a peripheral nerve stimulator with such a small technology, why is it so costly? It is costly because it is called as a constant current generator. I want all the postgraduates to remember this terminology. A peripheral nerve stimulator is one which produces a constant current output between 0.2 milliamps to 5 milliamps. So if you keep 5, exactly delivers 5 milliamps. So, and then there is a display of the current that you kept, that you see in this picture. So that is the display of the current. This is the knob which is used to change the amplitude, and a knob to control the knob to control the current intensity. The pulse width, here you see, this is the place where this is a basic model. You can keep either 1 hertz or 2 hertz. Then you have the polarity and a battery indicator. So what is polarity? So the positive electrode is attached to the ECG electrode, and the negative electrode is attached to the stimuplex needle. So this is the complete circuit. And one practical point that I wanted to tell you is, when you use this, the positive electrode, the ECG electrode, should be placed in a particular part of the patient's body, which you are able to see continuously during the process of giving the block. Because if you put it under the drapes, if possibly due to some reason there is a disconnection that happens, the positive electrode comes out of the ECG electrode, even if the tip of your needle is hitting the nerve, you will not get the desired evoked motor response because the circuit is not complete. So it is mandatory that the positive electrode is positioned in a place which can be seen by you when you're performing the block. This is the important practical tip I wanted to give. And when we use a peripheral nerve stimulator, it is important to use only insulated needle, so that the current emerges only from the tip of the needle. When you use a non-insulated needle, then the current disseminates through the entire shaft of the needle, and hence you will get false response, including direct stimulation of the muscles. So this is how the current emanates from an insulated needle, just from the tip. So these are the various types of needles, that Stimuplex X, A, and Stimuplex D, and you see the way the current emanates from the two different tips. And when you go on to an advanced model of a peripheral nerve stimulator, we have the HNS2, which is available in India. This HNS12 has got an additional advantage to know the impedance, and also you can go for the new the technology in PNS, which is called as the sequential electrical nerve stimulation. It is using 3 different pulse widths, 0.1, 0.1, and 1 millisecond. 3 different pulse widths that are given to make sure that you move towards the nerve. You are directed towards the nerve, and for successful placement of a peripheral nerve block. So this is a new technology which has come in. And now with the advent of ultrasound, we have got a lot of echogenic needles which can be used for a dual approach. Echogenic for the sake of viewing it under ultrasound, and it has got the capability of using a peripheral nerve stimulator. So we have Stimuplex Ultra, Ultraplex, Contiplex. Contiplex is one which is a catheter. A catheter which can be used for perineural placements. So the catheters that are used are divided into stimulating catheters and non-stimulating catheters. A non-stimulating catheter is you go for a single shot through the needle, like the Contiplex needle, and you reach the nerve, and then you take the stillet out and push the catheter inside. But the catheter cannot be stimulated. The disadvantage is maybe when you push the catheter inside, it may not be in the perineural area and it may move away from the nerve. And to make sure that even the catheter is it can be used with the stimulator, we have got the stimulating catheters. So as you push in this catheter through the needle, when you reach the nerve, you keep a small current, and as you push in the catheter, you keep on seeing the desired evoked motor response, and you know that you have placed the catheter close to the tissues. So here is an example of this is a continuous femoral catheter that has been put in place for a patient who has undergone a major reconstructive surgery of the thigh region. So these are the stimulating catheters. And perineural catheters also, we can use the same pump which we used for epidural pumps for continuous infusions. Then with the advent of ultrasound, as I said, we have gone in for new needles called echogenic needles. So the echogenic needles are specially engineered to increase the reflection of the ultrasound wave back to the transducers. So these are a major advancement in the needle technology to make it clearly visualized, especially the tip of the needle, because the advantage of using an ultrasound is to prevent the needle from injuring the tissues, and you wanted to clearly see the tip. And hence, we have got several kinds of this echogenic needle. Primarily, the one which you see on the right side, you see it's a micro laser etching. Basically, you increase the surface area on which the ultrasound wave hits, and when it is reflected back, the particular needle becomes much more prominent. So then we go on to the next advancement has been to find out the prevention of intraneural injection. And for this, we have 2 commercially available devices. One is called the B-Smart, produced by B-Braun. The other one is the Nerve Guard, which is produced by Pying. So this is a lovely, simple technology. You make sure that you put this pressure monitor between the syringe in which the drug is loaded and the extension tubing which is coming from the needle, and you see the pressure. And if the pressure is less than 15 psi, it is perfect. But if it's more than 15 psi, you're gone intraneural. So this is indicated by the color coding device. So it pops up based on the pressure at the tip. This pops up, and you know that if it's less than 15, you can inject the drug. If it's between 15 to 20, you're in the danger zone. There is a possible intraneural placement of the drug. So this picture clearly explains. The bottommost one is where the drug is placed. The tip of the needle has not entered the neural tissue, and you see the pressure there. And when it has entered the neural tissue, you see that the yellow pops up. And when you've gone deep inside and you have started injecting, the pressure builds up and the pressure goes more than 20 psi. This is not at all advocated because this will produce severe increase in pressure. And because of the increase in pressure inside the closed neural compartment, an ischemic component develops to the nerve because the vascular supply to the nerve gets jeopardized, and then you have produced a neural injury. So this is an excellent equipment, an injection pressure monitor that could be used. This is another one, nerve guard. It's another beautiful piece of equipment. Here, the advantage is the minute the pressure increases at the tip, automatically the guard closes. So you can no more inject the drug. Even by mistake, you cannot inject the drug. So this is called the nerve guard. This is produced by the Pyong. Any talk on regional anesthesia equipment will fail if I don't tell about ultrasonography. This machine, this piece of equipment has enhanced our ability in several ways, and it has made an anesthesiologist do so many things apart from the nerve block. You can put invasive lines, both arterial and venous, and the point of care ultrasound, which has become an inherent component of perioperative care. And anesthesiologists have taken lead roles in this because of using this piece of equipment. And just for those who have not used it, this is such a beautiful piece of equipment which clearly demarcates tissues. And this is the commonest block that you use. And if you see, this is about the block above the clavicle, and here you see this is the first rib, and here you see the subclavian artery, here you see the glistening pleura, and here you see the bunch of grapes, and that is the brachial plexus. So this piece of equipment has shown us that you can visualize the structures and you can push in your needle and place the drug close to the neural tissue. And this has made a rapid surge in the way regional anesthesia is being used in our country. And when you use techniques like this, you see the neural tissue. When you go in plane, you can track the entire needle, more so if you use an echogenic needle. At this juncture, I would wanted to tell, in a country like India, if you have a good ultrasound machine, is it important that you use only the prescribed needles, or whether you can still use hypodermic needles? I would think that once you become proficient in the way you identify the structures, if you become proficient in the way you can insert the needle, I think there is no harm in using a hypodermic needle, provided you know how exactly you're guiding the needle. You should never injure the nerve. It is possible to do with that, but for that you need expertise. And until you get an expertise, please use blunt needle. Once you become an expert, when you know that you have a great control of what you're doing, then you can use an hypodermic needle, which we use in our institution. The difference is the cost. And a hypodermic needle just costs 2 rupees. And the ultrasound machines have a lot of improvisation. This is an extended multi-beam, which is an inherent component of some of the ultrasound machines to make your needle visibility perfect, especially when you're in steep angles. And new technologies are coming in and day out in ultrasound. And now we have got the cordless probes which are present. Then advancements have happened in the probe, and also you know that the 2D ultrasound have become a 3D ultrasound, and we have also gone in for 4D ultrasound. But the biggest concern in a 4D ultrasound is the technical challenge of arranging close to 9,000 piezoelectric crystal in the transducer head. And if you ask a question, is 2D better or a 4D better to give a block, for example, a supraclavicular block, I would prefer a 2D, because in spite of the 4D ultrasound giving more dimensions, you can see the 3-dimensional with time. So the 4th dimension is seen. In spite of that, the 2D seems to be better because the lateral resolution offered by a 2D ultrasound is superior to that of a 3D or a 4D ultrasound. But I think it is important that all of us know that the technology of ultrasound is progressing so much that we will be able to use it for the betterment of our patient. See, these are the images which come from the 4D ultrasound. We see a three-dimensional effect. And the next thing is, most important thing when you use an ultrasound is needle guidance. So it has to go towards the structure that you wanted to push the needle in. And there are several technologies that are available. This is just an example. You see, a needle is attached to this is for in-plane technique. Along with the probe, you will have the needle that is attached to the side, and there's no need for you to do it. All that is, if you identify the structure, you just push in the needle in the trajectory that it is set in. But there are also other devices which are available, which works on electromagnetic tracking system, which moves the needle towards the targeted structure. Now, one of the other concerns for anesthesiologists was ergonomics, that they need to bend like lateral, and the curvature of the spine changes. Now, these Google Glass is an advantage. It's beautifully designed. For example, now if you see when you want to do a block, so the whole thing is there in your Google Glass. You need not even see the ultrasound screen. So everything is visualized in the Google Glass. So you directly go and give the injection, and there is no need for you to see the screen of the ultrasound. So this is another exciting technology that has come into place in regional anesthesia, and robotics in regional anesthesia. So this is the ultimate progress that we have come in, and there are published studies on using a robo-assisted ultrasound-guided regional anesthesia. But to become a good regional anesthetist, we also need to have good learning tools. And the phantoms are very, very important, especially for the young generation who are embarking into using ultrasound. And we have different types of phantom available: water phantoms, agar phantoms, blue phantoms, meat and cadavers. And every institution, teaching institution, should embark on a journey of using these phantoms and help the young budding anesthesiologist to needle through this, so that when they start using it on a human being, they are perfect and they're able to guide the needle perfectly well. So I've exceeded 10 minutes more than what was given to me, but I wanted to give an overview of regional anesthesia, and I am sure the future anesthesiologists have to become extremely proficient in using regional anesthetic technique, because if they do so, they are called as people who are innovative, who are world-class, who are very unique. And if you incorporate this into your day-to-day clinical practice, you become so proficient. I would quote an example. Here was a patient who came with a blood pressure of 240 by 140. He is a known case of coronary artery disease with triple vessel disease on dual antiplatelet therapy. He also had history of DVT and was an anticoagulant, and he was a hypothyroid on thyroxine replacement. His ejection fraction was 40%. He comes with, as I said, with a BP of 240, 140, a diabetic status of 400 with 1 ketone plus, comes with an ankle dislocation with excruciating pain with a small open wound. So now you need not worry about anything. You will think of going in for a site-specific analgesia, and this patient, we instituted a peripheral block with the help of an ultrasound, a popliteal sciatic block, and a saphenous infiltration. Within 20 minutes, the 240, 140 became 140 by 80. Patient completely became pain-free, and we went on to do a close reduction, because at that point of time there was a lot of swelling, and so a close reduction was done. And then subsequently, after 3 days, when the swelling subsided, again with another popliteal sciatic block, the ankle was fixed. So it shows clearly that if you embark into the journey of incorporating all the new technologies that is coming into your clinical practice, you get really empowered to treat patients with significant comorbidities with ease. So each one of you who are part of this webinar will embark on a journey of a jolly ride into the field of regional anesthesia to give smiling faces at the end of the surgery. And if you do so, you have done the job of being a perfect perioperative physician, a pain physician, and an excellent anesthesiologist who made sure that the single most concern of a patient when he comes to a hospital and when he undergoes a surgery, the most important thing that he thinks is whether he will have significant pain in the perioperative period. You and I can make a difference in their life by appropriately using regional equipments and regional anesthesia technique to make the whole process smooth, secure, efficient, and safe.